So we are live now. Asmita, we are live.
Great. Yes, ma'am, you can start.
Yeah, good evening, everyone. So we welcome you all to the next to this edition of the Thyroid Clinics organized by the Indian Thyroid Society. So Asmita, can we go to the next? So today we'll be having a very nice discussion on two cases and the quiz which all the residents wait for. So before that, I'll just give you a brief introduction about the Indian Thyroid Society. So this society was established and registered in 2003. And this society has healthcare professionals who have special interest in thyroid disorders, including the endocrinologist, the endocrine surgeon, the nuclear medicine physicians, the general physicians, surgeons, and ENT surgeons as well. ITS is also a member of Asia Oceania Thyroid Association, and currently we have around 2,000 members. Our founder president is Dr. R.B. Jayakumar, and our present president is Dr. Shashank Joshi. And Professor Sarita Bajaj ma'am is our previous past president. And the secretary of our society is Dr. Arun, and treasurer is Dr. Mini. And we also have our scientific committee where the vice president is Dr. Hima Girish Rao, myself, the coordinator, and joint secretary is Dr. Sujay Ghosh. And we have our EC members, Dr. Jabbar, Dr. Shashadri, Dr. Mohammad Riaz, and Dr. Sushil Gupta. And Dr. Ashraf, Dr. Mohan Shinoy, and Dr. Amya. So our aim is to organize academic activities for healthcare professionals and to promote public education and awareness about the thyroid disorders, and also to encourage the research in thyroidology. And we have our flagship journal, that is the Thyroid Research and Practice, which is under the Indian Thyroid Society. And we also have publications, multiple publications and multiple articles which are submitted and which undergo a peer review process. We also have a fellowship award of the society, and we also encourage more people to become member of this society. So we also do CMEs, updates, various thyroid clinics, which everybody attends, which include the journal clubs, the case conversations, and various panel discussions, meet the professor, quiz, workshops, and CPCs as well. So Thyroid Awareness Week, we do it between May 22nd to May 28th. And May 25th is celebrated as the World Thyroid Day. And the Thyroid Awareness Month is annually celebrated in the month of January. Also, ITS provides annual grants for original research studies which are focused on thyroid disorders, preferably in the Indian context. And the research grants, you can get the information about that from the website www.indianthyroidsociety.in. And we, as we already discussed, we have this journal. We have this journal which is in print as well as online. And there's a quick turnaround time, which all the articles undergo a peer review process. Electronic copies and online articles are available ahead of the print. And the fellowship is awarded to the ITS members who have expertise and experience in the field of thyroidology. The selection is through an expert panel, and the eligible members are conferred the Fellow of the Indian Thyroid Society, which we call as the FITS. We also released a book under the guidance of Professor Sarita Bajaj and Dr. Rajesh Rajput. And this was the ITS textbook which was released. And also we have released various consensus statements, including the thyroid disorders in pregnancy, which was published in our journal in the year 2023. And the management of subclinical hypothyroidism is under publication, and thyroid nodule also. These are the upcoming guidelines. And also the other ones are like hypothyroidism and diabetes for management of depression and thyroid dysfunction, and guidelines for the management of dyslipidemia and thyroid dysfunction. So this is our link to the guideline. You can access the guidelines. You can access through the ITS journal and the records of all the academic events and the online membership portal. So this is our website. Through this, you can have access, and there is a membership which can be done. And this is a life membership which is available for the endocrine surgeons, the endocrinologists, and nuclear medicine specialists, a full life membership. And there is an associate life membership for all the other registered medical practitioners. and you can apply it, as I told you, through the following link. So with this, I welcome our chairperson for today, Dr. Subodh, and hi, Dr. Subodh. And Asmita, can we have the slide of the introductory slide for the chairperson, please? So can we go to the next, Asmita? So he's a consultant endocrinologist. He's a professor of endocrinology at SAIMS Medical College and PG Institute, Indore. And he is the president of the Endocrine Society of India MP chapter and RSSDI MP chapter and Association of Physicians of Indore, and also the Diabetes Association Indore. So Dr. Subodh, I hand it over to you to take the session forward and first introduce our moderator, and then we go ahead with the case presentation.
So, thank you very much, Dr. Kalra. Thanks, Dr. Sarita Bajaj, for inviting us. Thanks, Dr. Shashank, if you are here, and all dear family members or executive members of our Indian Thyroid Society. It's very prestigious society, and I've been attached from the day one. You can say from the time Dr. Arvind Jayakumar was the president, he started this. And today we have very, very important sessions to be discussed. Hypothyroidism in the childhood as well as the adulthood, two different cases. And our endocrine department is there in SAMES, but we started DM program for this year only. So both the students are first year residents, but they are quite good. And without wasting time, I have a friend of mine from Bangalore, Dr. Jayanti Ramesh, will be chairing the session or moderating the session. And without wasting time, I would like to introduce him. He's a senior consultant endocrinologist at Sai Institute of Endocrinology, Hyderabad. Not from Bangalore, sorry, from Hyderabad. He's qualified MD, DM Endo, and DNB Endo. He is a recipient of prestigious PN Shah Memorial Oration Award for 2016, presented by Endocrine Society of India for his outstanding contribution to the endocrinology. He trained and nurtured several endocrinologists and PhD students across India with several original research publications, both in national and international journals. And is a former chairman of RSSDI Andhra. He's a special advisor, public health awareness activist, and culture ambassador for endocrinology. So without wasting time, I hand over the mic to Dr. Jayanti Ramesh. Please take over, and everything is yours now. I am just sitting on the back with Dr. Premila Kalra. Thank you very much. Thank you.
Dr. Jayanti, you have to unmute yourself. Unmute, please unmute yourself.
Thank you very much, madam. It's a very pleasant evening and pleasant meeting. And Dr. Subodh, Dr. Pramila Kalra, it's very nice. I interacted with the students who are presenting today, the wonderful cases and wonderful boys. They are very much interested in presenting the common thyroid problems, encountering in day-to-day endocrine practice, presenting with slightly unusual presentations. So they're going to present the interesting manifestations of or presentation of hypothyroidism, or quote unquote, let me say, it is undiagnosed or lately diagnosed, untreated consequence of long-standing hypothyroidism. Coming to the endocrinologist for the first time, passing through different, this one, they may come late to the endocrinologist, but then they would definitely end up in a better place. And since after diagnosis and reasonably simple treatment, most of these people, they become very good and have a good life. Let us work on these two things, but maybe at the end of the entire session, maybe I need to swallow a few words, what I said, that maybe all of them may not be having the best quality of life, but still then, yeah, most of them, because dealing with congenital hypothyroidism may be a difficult situation. But still then, I mean, catching them early, like the Indian Thyroid Society, I think we should proactively do something to catch them as early as possible, especially the congenital hypothyroidism of the child, the newborn, and then so they can go up along the life journey in a more successful way and bloom into successful adult with all that. With this introduction, I think I should invite the first presentation, Dr. Saumin, presenting. Can you just go with your case, man? Start.
Yes, sir.
Yes.
Yes, sir. Sir, is my screen visible?
Yes, Saumin.
No,
Yeah, your
not so
screen is
far,
visible.
Sumit.
Yes, sir.
Not so far. It was there before, but now not now.
Yeah. I'm just doing it. Yeah.
Otherwise, you can just send it to Asmita and we'll just, or me,
Okay,
and we
sir.
can share it. If
Okay,
you are
ma'am.
unable to.
Okay, ma'am.
That you are, if
Where
you are
do
not
I,
able to.
should I mail it, ma'am?
Yeah, you can just, Asmita, please coordinate, like he can mail.
Sir, your
Okay.
screen is on. You can just switch your presentation, sir.
Yeah. Is it visible now?
Yes, ma'am.
Yes,
Yes,
we
sir.
can see.
Yeah. Okay.
It is there. Go ahead.
Yeah. So I'll at the outset, I would like to thank the ITS and my HOD for giving novices like us this opportunity. So I'll start with my case. This is a case of Roshni, who is 6 years of age, female child, daughter of Gopal Singh, a resident of Nalkheda, Mahidpur, and belongs to a low socioeconomic status as per the modified Kuppuswamy scale. She came to us with the complaints of not gaining height or height faltering since 3 to 4 years of age, delayed development as compared to other children since 3 to 4 years, lethargic since 3 to 4 years, not playful since 3 to 4 years of age, and unable to tolerate cold since 3 to 4 years of age, and a history of vaginal bleed 5 months back. As per the mother, who is a reliable informant, child was apparently all right till 2 years of age, but after that she was not gaining height since the age of 2 years as compared to her siblings and other children of her age. She noticed that the child is not playful and active like other children of her age, and keeps an expressionless faces and is less interactive with parents, siblings, and other peers. And child used to lie down for most part of the day, with not being interested in surroundings and told only about her hunger and toilet needs. Apart from that, there was very little communication. She was developmentally at par with children of her age, but had height faltering at around 2 years. After that, she had she started falling behind children of her age in all 4 domains of development. And at 3 years, she was able to speak only bisyllables like mama and papa. And at present, she speaks only 4 to 5 words at 6 years of age. And that is why she is not even admitted to school at present. Child is not able to tolerate cold since the last 3 years. And she had a history of vaginal bleed, which was perceived as red colored urine by parents. And later on confirmed to be vaginal bleed by the pediatrician. Yeah. I'm sorry. Yeah. There is negative history of no neck swelling or leg swelling, no constipation, hoarseness of voice, herniation, delayed dentition, or excessive weight gain. As well as there is no history of any chronic infection and inflammation, no history of headache or visual disturbances. No history of previous hospitalization, blood transfusion, or any medical or surgical illness. The patient is completely immunized till 5 years of age as per her mother. The sibling history is that the child is born out of a non-consanguineous marriage. Age of father and mother at the time of conception was 29 and 26 years respectively. And there are 3 siblings, including the patients, with both siblings normal and not suffering from any similar illnesses, with no family history of mental retardation and short stature. The antenatal and postnatal events were uneventful, and breastfeeding was started within 1 hour of delivery. The child was born out of a gravida 2 mother via full-term normal vaginal delivery, cried immediately after birth with no history of asphyxia, and birth weight was 3.3 kg. The immediate postnatal events were also normal, and the child passed meconium just after birth and urine after 2 hours. And there is no history of any prolonged jaundice, neonatal hypoglycemia, or constipation in the patient. Coming to developmental history, the gross motor domain was delayed as the patient, as the girl is not able to skip. The fine motor domain is delayed as she is only scribbling at 5 years of age. The personal, social, and language is also delayed, with language being most affected, with only 1 to 2 words with meaning and 3.5 years of age. And dress, the girl child is only able to dress and undress at 5 years of age. Gross motor, coming on to developmental history, the gross motor age is 5 years. As there is no skipping. Fine motor age is 15 months as she can only scribble. Personal, social, and adaptive is 5 years as she is not able to interact with peers. And language age is 1 year as she can only speak in bisyllables. The developmental age and quotient of the patient, as calculated from the developmental history, is 45 months or roughly 3.75 years, and the developmental quotient is 36, which reveals severe mental retardation. The summary of the case, as per the history, is a 6-year-old female born out of a non-consanguineous marriage with a history of height faltering since 2 years of age and delayed developmental milestones, poor scholastic performance, and features suggestive of hypothyroidism, with history of vaginal bleed that presented to us, with the impression the provisional diagnosis on the basis of history was juvenile hypothyroidism with delayed developmental milestones and short stature with a history of vaginal bleed. Shall I
Dr.
continue?
Somin, yes, Dr.
Yes.
Somin, I think,
Yes.
can you please, the chief, what is a typical, the child is here, you said that there is a deficit in growth, physical growth, as well as
Yes.
mental, okay?
Yes.
That's what you said, and there is no obvious thyroid
Yes.
swelling.
Yes.
Okay. Then you also said about vaginal bleeding. I don't
Yes.
know what is the context of saying here about vaginal bleeding. What is the relevance here? Or would you like to elaborate upon it, both in the present
Yes.
illness as far as associated features are concerned?
Yes. Yes. Actually, sir, when the patient presented to us, the main complaint was of height faltering. And along with that, the patient also suggested to us that she had a history of red urination, which at that time locally they had sought a pediatrician consultation and they confirmed it to be vaginal bleed. And it is relevant in this case as in case of juvenile hypothyroidism or long-standing hypothyroidism. This can indicate some sort of precocious puberty, which can be GnRH independent also, as the girl has no other history of any breast development or growth acceleration.
So yes, but then as before even we are endocrinologists, we are
Yes.
basic pediatrician or basic doctor.
Yes.
And here we are dealing with a retarded girl child.
Yes.
Who would only ask for just indicate toilet, but most of the time if she was like, in that situation, a girl having vaginal bleed, in this has got some social context also. I think we need to inquire a bit and then also first think about the foreign body and other rule out, then only we should think of confirm that it is endocrinology cause of vaginal bleeding. The foreign body or anything, that sort of thing. Why
even abuse, sir, we did ask her about abuse also, any foreign body, any trauma she must have felt.
That wasn't there.
Yeah, any history of any infection at that time, any itching, any
discharge,
follicle, any discharge or any kind of local folliculite, any furuncle or anything like that. We did ask.
Having ruled out the local gynecological causes or whatever causes we thought, as an endocrinologist, what else did you think about this case before summarizing the history?
Yeah.
What other points relating to this vaginal bleeding you would have indicated in the history?
Sir, in case of vaginal bleeding, if there is also...
No. Tell me. Yes, please.
Yeah,
No.
in case of, sir, if the patient is, if the girl child of 6 years of age is coming to us with vaginal bleeding, there
Hmm.
should also be some concomitant secondary sexual characters that should be
Okay.
developed.
Yes.
Yeah.
What
So
about
any
that in the history? Because that's
Yeah.
again, you can easily ask to the
Yes.
mother, no?
Yes,
What
sir.
happened?
Sir, in case of this case, we did ask if there is any breast enlargement,
Okay.
any pubic hair, any
Hmm.
axillary hair,
Hmm.
or any of this or any growth acceleration which
Okay.
commonly occurs if there is a
Hmm.
premature growth spurt or precocity
No,
in
no.
any.
No.
Yeah.
Let us dissect these four things. You said that
Yes.
breast enlargement, you're correct, very much correct, because onset puberty starts with the thelarchy.
Yes.
Okay.
Yes.
Then you also say correct when you say that growth acceleration, but that's in the context of normal child. Here,
Yes.
you already said there's a lot of linear growth deviation,
Yeah.
deficit. So you cannot
Yes.
expect acceleration of growth. That we should
Yes.
not tell in the thing. But
Yes.
you say that there are no other appearance of secondary sexual characters. That's what you're saying, right?
Yes.
Okay.
Yes.
Okay. That's it. There's a vaginal bleeding in the with the entire overall background of whatever
Yes.
gave the history. Okay.
Yes.
With that, but lastly, at the summary, you said that impression is juvenile hypothyroidism with delayed development of milestones and short stature. But
Yes.
do you give any importance to vaginal bleeding, or just want to, or just to brush it off at this juncture?
No, sir. It is definitely one of the important factors.
So,
uh,
okay.
in
So, as
this
an
case.
endocrinologist, you need to
Yes.
think deep. You're saying that.
Yes, sir. Yes.
So maybe in that impression, you have to add that also.
Yes, sir.
With vaginal
Yes.
bleed needs further evaluation. Which
Yes, sir.
right? Okay.
Certainly.
Right.
Yes.
Carry on.
Yes.
How do you approach now with this? Are you entering into examination with these key points in history of a
Yes.
whatever growth you said growth deficit is there, significant
Yes.
mental developmental or the overall
Yes.
developmental deficit is there,
Yes.
and
Yes.
also vaginal bleeding is there. Now with this
Yes.
approach, let us, because every audience, youngsters or PGs who's listen, they should
Yes.
have this approach of uh, uh, evaluating the case from this angle, right? Okay,
Yes,
carry on.
certainly. Yes. So coming on to anthropometry, uh, and so the weight of the child is 14.21 kgs, which is between the third and the 10th centile, while the height is 90 centimeter, which is less than the third centile. The BMI is 17.3 kg per meter square, which is between the 23rd to 27th centile. The head circumference is 49, which is between the median and the first -1 standard deviation. The arm span is 85 centimeter, and the and the upper segment to lower segment ratio is 1.4:1. So while the expected was 1.2:1, that indicates a short limb dwarfism, short limb disproportionate short stature.
Okay.
Yes.
Then what is the extent of short stature here?
Yes, sir.
Please carry on.
Yeah, the extent of short stature, sir, I'll come to it. The SDS is actually -4.4.
Okay.
Yes. Yes.
So you're
So
saying here in this slide, you're projecting that height is less than third percentile.
yes,
Indicating the extent of short stature,
yeah,
you've first indicating percentile, and that is less
yes,
than third percentile. That
yes,
comes into severe short stature or moderate
yes.
short stature. False
So
as severe short stature, right?
severe short stature. Yes,
Okay,
sir.
now go forward. Now
Yes.
go forward.
The mother's height is 149 centimeters, so the father's height is 169 centimeter, with a mid-parental height being 152.5 centimeter and a target height of 160 centimeter. Yes.
Okay.
Now coming on to the growth charting, the plotting on the growth chart, the height age is 2.5 years, the weight age is 3.5, the chronological age is 6 years, and the bone age is 3 years, 2 to 3 years. The SD is 5 centimeter, while the standard deviation score is -4.4. With the
So
target,
you're not supposed to tell anything about bone age here because you haven't projected. Not supposed to
yes,
say, but then you should
yes,
have rather projected a growth chart,
yes,
plotted everything,
yes,
and
yes,
then
sir.
given a better depiction, because
All right.
anthropometry is key for pediatric thyroid
Yes,
case, right?
yes,
Okay,
sir.
right.
Yes,
Okay, carry on.
yes. Sir, coming on to the general examination, so this is the child. We can see that here that there are short limbs apparently. The anterior fontanelle is widely open, which should have been closed by 18 to 24 months. She has a puffy face. The hair are black, brittle, and lustreless. There is periorbital edema. There is a depressed nasal bridge. There is hypertelorism with epicanthic folds. The lower lip is a bit everted. The hairline is receding. The eyebrows seem to be normal, and there is a protruded abdomen with the SMR of A0, P1 and B1 Tanner stage.
You have provided a more clearer facial appearance, because
Yes,
that is
sir.
the most important. This is what is
Yes.
important, because
Yes.
from a distance in the crowded OP, postgraduate should be able to pick up what thyroid
Yes.
facious is, especially in a child.
Yes, sir.
Okay.
So this,
This is
I
important.
hope this suffices. Yeah.
Yes, this is what. So
Yes.
you have not only taken the head circumference, but you
Yeah.
also palpated for the
Yeah.
anterior fontanelle,
Yes.
which is, you're saying it's still open, not yet closed
Yes.
for this age
Yes.
child.
Yes, sir.
Okay.
Yes. Yes.
What is that understanding? What is the analysis? If at all, for this age child of 6 years, the anterior fontanelle is not yet closed. What do you mean? Where do you date this sort of disorder? Can you tell me something about it?
So anterior fontanelle should ideally be closed by 18 to 24 months. And
So this is something not done.
skeletal delay, maturation delay is
There is there. Okay, that's
Yes.
what is the indication.
Yes.
Right. Okay,
Yes.
fine. Skeletal
Yes.
measure. Yes. Next.
Yes. So coming on to general examination, the heart rate was 68 beats per minute, regular rhythmic, normovolumic with no radial of radiofemoral delay, a respiratory rate of 23 per minute, a normal temperature, normal SpO2, and the systolic and diastolic blood pressure were between 50 to 90th centile for the age. And
Have you measured with the pediatric cuff of that age?
yes, sir.
Appropriate
Yes,
for
sir.
that age.
Yes,
Right,
sir.
right.
Yes. We changed the cuff size for the pediatric one. We did do it that way.
What do you expect in such cases regarding blood pressure? What do you expect?
Sir, in case of hypothyroidism, there should be some diastolic blood pressure should be increased because of peripheral vascular resistance gets increased in this case.
Okay.
Yes.
Mm. Okay.
Coming on to the CNS systemic examination, the child was conscious, oriented to time, place, and person with normal higher functions and non-cranial nerves being normal. The DTRs were normal with delayed relaxation of
But
reflexes.
boss, you said there was global developmental delay in history, and you're saying
Yes.
higher functions are normal. Is it not contrasting paradox? You only said that there is
Yes.
developmental delay is gross, global developmental delay in the history,
Yeah.
and the child is higher functions are normal.
In
I
terms
mean,
of
that is something.
yeah, in terms of sir comprehension and in terms of memory, speech, uh, she was able to comprehend. She was able to speak properly. There was no apparent memory loss also, which is like we expect some sort of delay in verbal recall in such patients. In short-term memory loss should be there, but it wasn't there in this case.
This is something, I mean, I think higher functions, I think this doesn't fit well for because you have opened up
Yes.
and you have summarized that there is
Yes.
a global developmental delay, and you also quantified the mental age for pointed
Yes.
at that it's something like 34 months or 30. And
Yes.
then you're saying that she's total higher functions are normal. At least that statement you should not give so emphatically, right? This,
Yes.
I don't think that you should project so matter of factly, right? This needs
Okay.
more measure, right?
Yes.
Carry on, please.
Yes.
Hmm.
So there is delayed relaxation of reflexes. While the superficial reflexes are normal, they are present. Babinski is negative. Coordination is normal. The gait is normal. We looked at the gait in case of there is any limping or anything with regards to SCFE later. We had that in mind while checking this. The sensory system is normal, as well as cortical sensations are also normal, like point localization, 2-point discrimination. The cardiovascular.
No, Mr. This is a thyroid clinic. So what
Yes.
we want to know is this child who is so with whatever picture you gave, you gave a suggestion that probably the child we are dealing with some sort of thyroid disorder,
Yes.
long-standing
Yes.
some thyroid deficiency, probably, but actually we need to
Yes.
discuss some differential diagnosis also. But in that
Yes.
situation, what is the muscle? How did the muscle look like? How is the stiffness? Did you obviously
Yes.
feel something or whatever? That also you should have given. Okay,
Okay.
peripheral
Yes.
muscle how is that? अब नहीं
Yes.
बोले cortical
Yes.
senses पूरा point localization कर लिया नो 2 point distribution काफी normal है थोड़ा okay. Okay,
Yes.
these are all I'm raising, please.
Yes. Yes.
Nothing, there's nothing against it. Please, this is a
No, no, not at all.
learning
Yes.
session, and the
Yes, sir.
entire whoever
Yes, yes, sir.
Indian Thyroid
Sure.
Society people are listening,
Yes,
everyone,
sir.
they are free
Yes,
to
sir.
also
Yes,
raise.
yes.
But these are something we should not. Indians should never think like that, right? We have to think
Yes.
more globally, and we have to accept our mistakes and go forward.
Yes,
Next,
yes.
go
Certainly.
forward again.
Yes.
देखो,
The CVS and respiratory
Hmm.
systems are within normal limits,
Okay.
normal examination. Per
Hmm.
abdomen, sir, there was a protruded abdomen,
Hmm.
soft and non-tender with no organomegaly, and
Okay.
bowel sounds were present and hernial sites were intact.
Achha, okay, I'll just do something. You said perabdomen or no organomegaly. Suppose in this sort of case where the growth deficit was there, mental retardation was there, according to you. Okay,
Yes.
leave aside that vaginal bleeding, keep aside for some time. If the
Yes.
organomegaly in such a case with what else you expect in differential diagnosis?
Sir,
In
the
such a-
glycogen storage disorders we can think
Okay.
of.
All
GSD
storage
type 1.
disorders. You'd
Yes.
like to see all
Yes, sir.
storage disorders,
Yes,
right?
sir.
That's
That
correct.
can
Yes.
also present with hepatomegaly, hypoglycemia, doll-like facies.
Yes.
That can be
So
there.
that comes closely. That's what in your mind is saying.
Yes.
That these are the differential probably you must be.
Yes.
Okay, fine. That's good. That's good.
Yes.
Right.
Thank
Carry on.
Yes. Sir, summarizing the
Hmm.
patient on the basis of physical examination also. 6-year-old born out of a non-consanguineous marriage with a history of height faltering since 2 years of age, a delayed developmental milestones and symptoms of hypothyroidism, presented with above complaints and on examination was found to have myxedematous facies, disproportionate short stature, significant mental deficit, and a non-palpable thyroid, and a history of vaginal bleed.
Okay. Okay.
Yes.
So basing on this history, then what are you giving? Any
Yes.
diagnosis, provisional diagnosis, or you're
Yes.
putting up any DDs, clinical and history
Yes.
examination?
So clinically,
wise?
yes, sir. Yes, sir. Clinically, the provisional diagnosis we were thinking was in terms of juvenile hypothyroidism, a long-standing, untreated juvenile hypothyroidism, and we were thinking in terms of that can explain the short stature also of the child and a delayed developmental milestones also, the intellectual deficit. Along with that, the vaginal bleed can be because of a very high TSH or uncontrolled hypothyroidism. That was something that we kept in mind when we ordered our investigations.
Okay.
Yes.
What else? Like before, as I said, before becoming endocrinologist, we are pediatrician or whatever.
Yes.
So that should carry on. Pediatrician
Yes.
or general medicine.
Yes.
So naturally, nutritional disorder
Yes,
or
sir.
hemoglobin, which is
Yes.
very less,
Yes.
and maybe hypoalbuminemia, maybe atypical. That may be also there,
Yes.
but minus that
Yes.
severe
Yes.
mental deficit
So
and
yes, sir.
vaginal bleed. Yeah,
Yes, sir. We also asked the child whether she was immunized. She was immunized till 5 years of age, as per the mother. She also had no signs of any chronic inflammation or malnutrition, chronic chronic inflammation or infection either. There was no failure to. There was no recurrent pneumonias were there. Nothing of that sort was there. So we wanted to rule out all these things. Chronic anemias, any history of blood transfusion was also sought.
Yes.
That was also not
Because
there.
in pediatrics, hematological disorders they prevail,
Yes.
nutritional disorders prevail.
Yes.
And
Yes.
suppose in this case there was a obvious thyroid swelling,
Yes, sir.
then definitely you can jump to
Yeah.
this. But here
Yes.
there's absence of thyroid swelling.
Yes, sir.
And
Yes.
other clinical pointers to this one, other differential diagnosis you have to entertain, then you have to exclude.
Yes.
Right? That's
Yes.
what is the thing. That's why
Yes.
I'm raising this point.
Yes.
Yes, that's fine. This is good. You carry on.
Okay. So we ordered the hematological investigations, the tier 1 investigations, namely the hemogram. The hemoglobin was 11 gram per deciliter. MCV was it was a normocytic normochromic picture with normal WBCs and platelets. The creatinine was also normal, 0.6 milligram per deciliter. And AST, ALT were also within normal limits. The albumin was 4.4 and the alkaline phosphatase was 92.6. All were within normal range.
So just now we discussed about other
Yes.
differential diagnosis,
Yes.
and you can find it here
Yes,
that
sir.
you are narrowing and then
Yes.
pointing somewhere. That's
Yes.
the approach of the case diagnosis, and is like that. Though that's
Yes.
that's fine.
Yes. Yes.
That's very good. Nice. Carry on.
Thanks.
Then here, having
Yes.
done this as an
Yes.
endocrinologist, okay, carry on.
Yes. Yes, sir.
Okay.
We also went for some calcium, vitamin D, phosphorus. They were also within normal limits.
Okay,
The-
Master. One missed. I
Yes.
understand that you've
Yes.
ordered for hematologic, blood
Yes.
test and all.
Yes.
They are available.
Yes.
But
Yes.
before blood test, seeing in the
Yes.
endocrinology clinic, after going through that history and then whatever you said, the negative
Yes.
points related to general
Yes.
pediatric illnesses,
Yes.
what is the first investigation you
The
would
bone
like to
age.
do?
Bone age. We
You
should
wanted to
go
go
for the
bone
bone
age.
age.
Okay,
Yes.
then you're gone for
Yes,
this.
sir. We
Okay,
did the
that's
bone
what
age
that
first.
that approach is fine.
Yeah.
That's what
Yeah.
I wanted to answer.
Yes,
Okay.
sir. We
TSH
did
is
do
so
the
high.
bone age. Yes. Yes.
TSH काफी high है.
TSH is, sir, more than 2250. And the free T3 is also 1.39, which is below the normal range. And the FT4 is very less than 0.068 nanogram per deciliter. And the anti-TPO is also positive, sir, at 67 international units per ml, with the prolactin being 41.7 nanogram. Yes.
But
So-
despite so much of that means the sensitive what? Sensitive of what?
So this is
Biochemically?
biochemically, sir. This is primary hypo
Okay, fine.
thyroidism.
Severe primary hypothyroidism. Yes.
Severe primary.
Despite that, there's no, what is the striking there? What is not there?
Sir,
Despite that severe.
the prolactin should have been higher.
No.
Maybe.
More simpler things you should tell. Dyslipidemia is expected to be there. Even in
Dyslipidemia
a
is
child, that's
expected.
not
Yes.
there. Okay.
Dyslipidemia is
And
not.
hemoglobin, okay, fine.
Yes.
Carry on.
And hemoglobin is also not that less. It
That
is
less.
even. Yes.
What do you expect? Which sort of hemoglobin? What is the hemoglobin? What type
Sir,
of anemia you expect in
Sir,
this sort of?
pernicious anemia can be there. MCV can be higher. Normocytic, normochromic anemia can also be there. As of anemia of chronic disease can also be there.
Yes. Why do you talk of
Yes.
pernicious anemia, man? First, tell more
Yes.
things. Chronic
Yes.
hypothyroidism can have
Yes.
two things. One is, it can suppress the
Yes.
basic this one. Okay.
Yes.
Right.
Yes.
Okay. Right.
Yes.
Carry on. Even macrocytic anemia. Okay. Right.
Yes.
Carry
Yes.
on.
So we also ordered the USG thyroid, which was suggestive of a small
Pale
thyroid gland.
Baba. We'll
Yes.
come to this, but project bone age, man. For people who
Yes.
are listening, they have to have this. This is a bone age.
Yes.
Achha, what happened? What is the bone age? You
So
tell me.
bone age is 2 years, since only 2 carpal bones are there.
तू मतलब 2 दो ही कार्पल है इसलिए 2 साल है 3
Yes.
कार्पल है तो 3 साल है
नहीं,
4
yes.
साल ऐसे नहीं कितने
Yes.
बोनेज आप इतना क्लियरली कैसे बोल रहे हो 3
Yes,
years के
2
नीचे रहता भाई
2 to 3 years of
3
age,
years
sir.
के
Yes,
नीचे
sir.
रहता
Less than
under
3
3
years
years
of age.
under 3 years
Yes.
you can tell right
Yes,
okay
sir. Yes.
fine okay तो आप क्या बोल रहे हो डिले हुआ क्या काफी डिले
Yes, sir.
है
Yes,
तो
sir.
अभी
Yes.
तक ओके अब यहाँ पे बोलो क्रोनोलॉजिकल एज कितना है
Chronological
6
age, sir, 6 years है.
हाइट एज कितना था
2.5 years.
What is the
And
bone age? 2 years.
Bone age is 2 years.
हाँ तो आपको क्या आ रहा है कि the fellow is a linear growth deficit with delayed
Yes.
bone age, right?
Yes. Yes. Yes.
With anyhow आपने तो biochemically confirm कर लिया. Okay,
Ji.
right. Carry
Yes.
on.
Yes. So we also this also we went for the hip and the knee, and
Hip क्यों project पहले वो project करिए hip project करिए please.
yes.
I think
yes.
we should we'll just project. We'll just
Yes.
क्यों कराए भाई ये? Why did you get it done? इन्हीं का
Sir,
है ना? For that child
sir.
only. हाँ.
Yes, sir. Yes.
Okay.
Yes.
तो क्या दिख रहा है भाई थोड़ा नीचे femoral end पे थोड़े बहुत स्लाइड
Yes.
कुछ मिनरलाइजेशन प्रॉब्लम्स दिख रही
Yes,
चलो
sir.
अच्छा
Yes.
femoral epiphysis देखना चाह रहे थे
Yes,
क्या
sir.
आप इसलिए चेक
Yes, sir.
कराए
Slipped SCFE के लिए sir, slipped capital femoral epiphysis. We wanted to
अच्छा
see. Yes,
why
sir.
did you expected that because long standing hypothyroidism was there
Yes,
that's
sir.
how you
Long
wanted
time.
to do it
Yes, sir.
okay
Yes, sir.
fine
Because
that's why you projected
yes, sir.
but you
Fragmentation
didn't
of
find anything
Yeah, fragmentation of the ossification centers can happen, sir, in uncontrolled juvenile hypothyroidism. That
Wait,
can-
suppose you're saying it's a pediatric and the child you're saying from young age. So I'll say it is congenital hypothyroidism. Basing on the X-ray, can you tell me that whether it could be congenital hypothyroidism or not, or maybe only on radiograph? I mean, there are many other factors, but can it be congenital hypothyroidism or can be a juvenile hypothyroidism? I'm just throwing a sort
Yes.
of this one. अब सपोज कंजेंटल हाइपोथायराइडिज्म में बोन डैमेज काफी एपिफाइसियल डैमेज ज्यादा रहता या इस
Yes.
तरह which में
Sir,
ज्यादा रहता है?
Sir, epiphyseal damage will be more in case of congenital hypothyroidism.
Okay. Now at
Yeah.
this point we want you to understand, or let us
Yes.
all understand, let us all pinpoint that epiphyseal damage would be more in that. Okay, carry
Yes.
on. Next, carry.
Yes.
Please. I
Yes.
think time is okay.
Yes, sir.
एक्सेस कल क्यों करवाया समझ में नहीं आया मेरे को.
हाँ, yes, sir.
किस वास्ते करवाया? हेडेक बोली थी, वॉमिटिंग्स तो नहीं बोले थे ना?
नहीं सर, हेडेक नहीं था, बट
कोई विजन डिस्टर्बेंसेस थे? नहीं
थे सर. ऑफ एंड ऑन कभी कभार होलोक्रेनियल हेडेक, ऑफ एंड ऑन मदर ऐसा बताती थी. So we had thought that is there in case of any sella enlargement is there or not?
Because of the clinical long-standing hypothyroidism.
Hypothyroidism.
Clinical biochemical. Yes, you're correct. Yes, carry on.
Yes. And sir, we also went for the ultrasonography of the thyroid gland, which suggested a small thyroid gland which was hyperechoic in ecotexture. And the radioiodine scan was also planned, sir, but we could not get it done because of the financial constraints.
Okay.
Coming on to sir, another hormonal assay which we try, hormonal investigations, FSH was 3.6.
नहीं पहले अल्ट्रासाउंड बताइए फिर जाएंगे बाद में. अल्ट्रासाउंड के बारे में पहले बताइए. वहीं पे लिखा हुआ है उसी टाइप स्लाइड पे प्रोजेक्टेड है. अब अल्ट्रासाउंड एब्डोमेन बताइए. अब वेजिनल ब्लीडिंग हुआ बोल के अल्ट्रासाउंड करवाएं.
यस सर, यस.
तो क्या दिखा? अब व्हाट वर यू एक्सपेक्टिंग? व्हाई डिड यू डू अल्ट्रासाउंड एब्डोमेन? दिस केस ये ऑर्गेनोमेगाली तो है ही नहीं था ना.
नहीं सर. We wanted to look for the ovarian size and whether there were any follicles, because vaginal bleed in case of a patient of untreated primary hypothyroidism, because the TSH as well as the we just wanted to look for the ovary size.
Vaginal bleeding आप बोले हो ना. Earlier you ruled out foreign body and other things.
Yes, sir.
Now you have said vaginal bleeding, is it coming from the uterus or not?
Yes,
that's what.
Precisely.
So naturally, and uske uterus ko activate kaun sa karte? Ovaries, and they have got some issues. They may hate it. So okay, ovaries you have checked it, and with all that, what you're saying, chronic long-standing hypothyroidism, maybe ovaries, maybe some problem may be there. What problem you expected? The ovaries?
So we expected multicystic ovaries to be present in this case, which we also found. There were multiple follicles of varying sizes in both ovaries, of 8 cc and 4 cc respectively, with the largest measuring 2.9 into 2.1 centimeter, and which is present with discordant for age and the prepubertal sexual maturity readings.
मतलब
सर इसको हमने कोरिलेट करने की कोशिश करी थी SMR से.
अच्छा ठीक है. तो अल्ट्रासाउंड एब्डोमेन नहीं बोलते वहाँ पे, अल्ट्रासाउंड पेल्विस लिखना होता है.
पेल्विस, यस.
हाँ, तो पेल्विस है उसके. और क्या देखना चाह रहे वहाँ पे? और क्या दिखाएंगे? यूट्रस के बारे में नहीं बोले ना कुछ भी.
हाँ, यूट्रस भी सर, it was not A plus, मतलब it was uterus was there was no agenesis, normal for the age था as per the sonologist.
देखो यहाँ पे नॉर्मल फॉर कहाँ से ब्लीडिंग आया? देन यूट्रस के थ्रू ही आना ना. तो यूट्रस एंड मेजरमेंट्स तो लिखना चाहिए था. Okay. Oh, that's what you present, right? Because when you are dealing with, even though we are dealing with pediatric thyroid case, everything is interrelated. So simultaneously, puberty wala issues also fundamentals they come in place, because you projected some biochemical test there. Okay.
Yes.
Right.
Yes.
Bolo.
Yes.
Kya hua?
Sir, FSH and LH were also done. FSH was 3.6 billion international units per ml.
Okay.
And LH was 0.243. So we had FSH was higher and LH was lower.
सिस्टिक ओवरीज का पिक्चर कुछ प्रोजेक्ट कर सकते हो? नहीं है आपके पास?
सर एक्चुअली वो था नहीं, वो यस सर, इट वाज
नहीं
नॉट
था.
यस,
करना था, रखना था भाई. इंडियन थायराइड सोसाइटी को प्रोजेक्ट कर रहे हो, ये सारे तो कुछ रखना चाहिए ना.
Yes,
Because you see, for many other people, everyone, even every senior person also would have a different experience with one
yes,
image, right? Okay,
yes,
right.
yes,
Carry on.
yes,
तो अब क्या आप समराइज करना चाह रहे हो पूरा कुछ
yes,
मिला के
yes.
फटाफट 3 लाइन में बोल दो फटाफट.
Diagnosis,
Okay,
हाँ,
okay.
yes. So the diagnosis was made of a long-standing primary juvenile hypothyroidism with GnRH independent precocious puberty with multicystic ovaries and delayed bone age. And this symptom complex is collectively known as the Van Wyck-Grumbach syndrome.
यहाँ पे GnRH इंडिपेंडेंट प्रिकॉशियस प्यूबर्टी बोल रहे हो. प्रिकॉशियस प्यूबर्टी का तिलार्की नहीं बोले, यूट्रस के बारे में नहीं बोले. ओके, सो एंड आई डोंट नो बट GnRH LHF says okay, but then we should have projected. Okay, we know that long-standing juvenile hypothyroidism or whatever can give GnRH independent precocious puberty, but I mean you need to have a more comprehensive approach, right?
Sure,
Okay,
sure, sir.
but you can develop in it, right? Carry on.
Yes, yes. The patient was started on thyroxine 50 microgram per day, sir. And actually the cortisol was also done, but it was 8.62 microgram per deciliter fasting cortisol. So it was started 50 microgram per day without any cortisol cover. And
See,
the
50
patient,
microgram per day in pediatric setting, you have to talk in terms of per kg body weight.
yes, sir. It was started with 4 microgram per kg body weight. Yes. 14 kg की patient थी, तो we started around 50.
Okay.
With the view of not compromising her final adult height also. So we were not very overzealous.
What are you concerned about at this stage of starting the treatment? Is it the final adult height or something else at the starting of treatment? Why should we be careful?
It is the normalization of the TSH and also biochemical as well as the quality of life the patient should.
So how, I mean, yours is what? Swifter and quicker control of normalization of TSH, or it's a gradual, systematic control of thyroid status. What is that you choose here in this case? This or that?
We chose the gradual method.
Why did you choose that? Anyone should choose that only. I mean, there's no quicker and swifter normalization. Why in this situation? Why should we be careful? Why did you choose this?
Because thyroxine can also cause the increase in the metabolism of cortisol can occur, and secondary adrenal insufficiency can occur. And secondly, then there is also a problem of idiopathic intracranial hypertension can also occur if there is quicker treatment is initiated.
Yes, you've already done something. There's enlargement there. Correct.
Yes.
You're correct. Slow and systematic is very important.
Yes.
That we need to emphasize. That's the only point we need to emphasize. Rest of things follow up karenge. Okay, that is what you're doing. Then you want, what are your goals of treatment in this case? Management strategy kya hai? One is that, bolo. Three.
So one is that we will gradually up titrate the treatment. We'll look at her anthropometry and growth. We will check for that. We will every 3 months go for a. We'll also go for the USG thyroid also after 3 months, and we also want to check for the USG pelvis and everything, and the so that we can see that the most of the things are reversible on proper prompt treatment. And we'll also look for headache and visual disturbances in this case. Is there any headache? Is there any visual disturbance in this case? Because long-standing hypothyroidism can lead to thyroid hyperplasia, and that can compress on the optic.
So slow, gradual, systematic, and effective normalization of the thyroid status and growth monitoring. And monitoring of the other parameters, monitoring of the nutrition, as well as and assessment, improvement in cognitive, to what extent it can be done. Okay. Other team, you want to involve other team in this, in the treatment? You want to involve other team also? Any other members in the team?
Yes, sir. The pediatrician can help with the nutrition also.
Okay.
And
next. Yes, next.
Then the
Rehabilitation, neuro rehabilitation.
neuro rehabilitation and the
yes.
psychosexual, also psychosocial rehabilitation of the patient is also
Yes, that's
necessary.
what is important. So this case tells us very important that multiple system,
Yes.
but endocrinologist should be able to coordinate in such a way that the child, we can reach the maximum possible treatment goals in an effective and smoother way and long-term, lifelong follow-up in this patient, right?
Yes. Yes.
Okay.
There are 3 4 questions in the chat box. If we can just take some of them.
Yes.
Yeah. There are 4 questions. I'll just read it out. One
Yes,
question is only for ECG and echo. Was bradycardia and all that there, and ECG and echo was done.
Yeah.
The
Yes,
second
ma'am.
question is for, was the child taking non-iodized common salt? That was the another one. And
Yes.
was the newborn thyroid profile available or not and studied? And can this child be labeled as juvenile hypothyroidism, because or should we label it as congenital hypothyroidism? So that's basically the next question.
I think the last person needs to be answered first.
Yeah.
Master, yes, can you
Yes.
answer, Swami?
Yes, sir. Ma'am, the last question, please, can you repeat it? Yeah.
Congenital hypothyroidism versus the childhood juvenile hypothyroidism. That's
Yes,
the
sir.
question.
Yes, sir. So, in case of congenital hypothyroidism, sir, there would be some sort of delayed birth can be there, post maturity can be there. There can be prolonged neonatal jaundice. There can be neonatal hypoglycemia. There can be constipation in the patient. These things were not there, sir. And any
in this child, in this particular case,
yes, ma'am.
why are you saying juvenile and not congenital is the question?
Yes, ma'am. Ma'am, because there is a specific we can locate around 2 to 3 years of age. The child was doing well developmentally also. There was no history of any antenatal or postnatal natal history of any untoward events. The girl was the parents were in a iodine replete environment, and there was that, and these were the things, ma'am.
So congenital will be present from birth.
From birth,
very severe.
Yeah.
At
Immediate perinatal events would be
very,
there.
very severe mental retardation.
Yes.
The patient has not. So that is the crux of the matter over there.
And no family
And
history.
are you sure about the
Ultrasound
history
showed
of
that she had a
iodized?
thyroid.
Sorry.
Yes.
So what?
Ultrasound showed that thyroid was present. And the second thing, and the family history was not there for diseases. Third thing, anti-T2 antibodies were positive. So all those, the subtle point is paper that it is more of a juvenile rather than congenital.
Yes.
I think the one point which pins out is that, I mean, the mental age and other developmental could be something like 34 months and all. So maybe congenital hypothyroidism will have a severe, as madam was saying, severe deficit from the beginning. All the perinatal events, the one there.
Yes.
Yeah, so we need to move on to the next case, of course, after the quiz. The one Parag Agarwal is asking how much difference between chronological age and bone age is significant to call delayed or advanced. So, Amin, would you like to answer that?
Yes. Hello. Yeah.
Yeah, go ahead.
Yeah. So, ma'am, it is more to do with just a second. Yeah. It is more to do with there is no cutoff as such, but the more the difference between the chronological age and the bone age, that seems to be pointing towards a greater delay or a greater hormonal deficit in this case. And the SDS score also can relate to that better rather than just a absolute difference between chronological age and the bone age.
Yeah. Any centiles that you follow, or it's just a number? It's a numerical.
The centile, ma'am, if the SD is minus 3 SD is dwarfism, that is very severe. If it is less than 2 SD, then it is short stature. And less than third centile is severe. So less than third centile, we would always think of as being a severe deficiency.
So I think we'll move on to the next part of the clinics.
ma'am.
That is the, otherwise,
Quiz,
yeah. Because it's
So
40
now-
minutes per
yeah.
case, but we've overshot here.
Yeah. So Dr. Subodh, you can introduce Dr. Lisa. She'll be going through the
Sure.
quiz. So then I will tell the quiz rules after that.
I hope everybody is ready for the quiz. It's exciting. So we have Dr. Lisa, who is going to present it. She's currently consultant endocrinologist in internal medicine and Department of Telemedicine, PGI, Jitma, Chandigarh. She's MD, DM, and Associate FAMS. She has achieved triple gold medals in her MD, 65 papers in peer-reviewed journals, a big number. David Klein, Career Pituitary Investigator Award, in IES-PMR Research Grant 2022. She's Associate Editor, Editorial Board of Frontiers and Endocrinology, Pituitary, PLOS 1, and IJEM case. She's a reports and reviewer of national and international journals, guest faculty for lectures at US Endocrine 2020, Atlanta, Georgia, in Pituitary Symposium. So I think the quiz looks like it will be very, very tough. So everybody should be ready. Over to you, Dr. Lisa, please. Thank you.
Yeah, before Dr. Lisa, you start the quiz, I'll just tell the quiz rules and then you can start. So the important thing is that you should have a Zoom app on your mobile device or laptop before you participate in the quiz. A laptop is preferable, and because that will make your experience easy. The quiz will run for 10 minutes. There'll be first 2 dummy questions and then followed by the actual quiz. And Dr. Lisa will display the case or the description of the question by screen sharing on the PPT slide, and participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions is to be submitted at once at the end of 10 minutes. And to read the case or description, you can choose the polls using the X button and again use the polls option to answer the respective questions. So can we have the dummy question? Asmita, can we have the dummy question? Yeah, so in which city is Taj Mahal? Chennai, Mumbai, Agra, or Bengaluru? And how many oceans are there? 8, 5, 6, or 7? So these are the 2 dummy questions. And now, Dr. Lisa, you can please start the quiz.
Unmute yourself.
Unmute.
Dr. Lisa, unmute yourself.
Yes. So first of all, good evening to everyone, and thank you very much, Dr. Sarita ma'am, Dr. Subodh sir, Dr. Pramila, Dr. Jayanti Ramesh, and the entire panel of the Indian Thyroid Society for giving me this opportunity. And without much ado, I'll be starting the quiz. So Dr. Pramila ma'am has briefed about the So she's already briefed about the rules. So I just wanted to, to confirm if the screen is visible.
Yes, ma'am. It's visible.
Okay.
Yes.
Thank you. Thank you. So moving straight on to question number 1. So all the best to all the participants. Yes. Which of the following is true about McCune-Albright syndrome? So option 1, differentiated thyroid cancer is commonly reported. Nodular goiter is seen. Antithyroid drugs are the treatment of choice for McCune-Albright syndrome associated hyperthyroidism. And the pattern resembles a T4 toxicosis. So which of the following is actually true about McCune-Albright?
Ma'am, move to the second question.
Okay, great. So question number 2, this is actually one of the research from one of the panelists, Dr. Pramila ma'am. So regarding hypothyroidism after subacute thyroiditis, which of the following is false? So the severity of subacute thyroiditis does not determine the development of hypothyroidism. Permanent hypothyroidism is seen in nearly 20% of cases at 1 year of follow-up. Greater prevalence is reported with longer duration of follow-up, or recurrence of thyroiditis can be seen in up to 2% of cases. So 3 are correct, 1 of them is wrong. You have to tell me which one is wrong.
Third question.
You can move to the next. You can. Yeah.
Now, question number 3. So, which of the following is not an adverse effect of tyrosine kinase inhibitors, which are used for medullary thyroid cancer management? Bowel perforation, or is it glomerulonephritis, hand-foot syndrome, or hyperthyroidism? Which is not an adverse effect?
You can move to the next.
Right. So this is actually about thyroid eye disease. This is one of our patients which we reported. So is it always bilateral or asymmetric? Can it coexist with other ocular pathology? Is superior rectus the most common extraocular muscle involved? Or all cases of thyroid eye disease have Graves' disease? Which of the following is correct?
Ma'am, move to the next.
Okay. So this is about IGSF1 deficiency, that is immunoglobulin-like superfamily 1 deficiency. Is it the most common cause of congenital central hypothyroidism? Boys with IGSF1 deficiency have small testes. The mode of inheritance is autosomal recessive, or hyperprolactinemia is seen in up to 50% of patients, which is true.
You can move to the next.
So teprotumumab, all of you are well aware. So which of the following is applicable to this drug? It is FDA approved only for active thyroid eye disease. It is orally administered daily. It is being successfully used to treat myxedema coma, or is it prescribed in weekly dosing by the IV route? Which is correct?
We can move to the next.
So this is about thyroid dysfunction and proteinuria. Which of the following is false? Hypothyroidism can cause proteinuria. Hypothyroidism can cause reversible EGFR decline. Levothyroxine replacement can reduce both proteinuria and improve the GFR. Or the minimum duration of treatment required for improvement is 18 months, which is false.
We can move to the next question.
Okay. Now moving on to TSH-OMA or TSH secreting pituitary adenoma, which is true. Hyperprolactinemia is never a feature. Is it more common in females? Surgery followed by somatostatin analogs or radiotherapy can be used for treatment. Or are most of the cases diagnosed in the second decade?
Next question.
Okay. So regarding myxedema coma, which of the following is most appropriate? Is it more common in elderly males? Is it reported only in drug defaulters who are previously diagnosed with hypothyroidism? Apache 2, SOFA, and myxedema scores have all been used for prognosis, or mortality in this condition is very low, which is correct?
We can go to the next.
Yes. So this is about alemtuzumab-induced thyroid dysfunction, which is false. So both hypo and hyperthyroidism can be seen. Thyroid eye disease has a better prognosis than Graves. TRAb levels are highly positive. Or does alemtuzumab-induced Grave require longer time for normalization than conventional Grave?
Next.
Yes, I think this is the last one. So regarding the perioperative management of non-thyroidal surgeries and thyroid disease, which is most correct? Is ketamine the induction agent of choice for hyperthyroidism? Is it the agent of choice for hypothyroidism? Parenteral T4, if needed post-operatively, should be given as 20 to 30% of the oral dose requirement, or LT4 replacement is mandatory prior to cardiac revascularization. Which of the following is correct?
Yeah, we conclude the quiz and then you have to give the answers at the end of the second case discussion and then announce the winners as well. So please stay with us.
Yes. Thank you.
So we go on to the discussion for the next case. So Dr. Subodh and Dr. Jayanti, we can start the next case.
Yes, please.
And we can start the next, yeah.
Dr. Pandey. Dr. Siddharth Pandey, are you ready with the case? Please go ahead. Dr. Jayanti, you want to introduce? He's a first year, DM student in our college, Department of Endocrinology at Sri Aurobindo Institute of Medical Sciences, Indore. Over to you, Dr. Pandey, please.
Yes, good evening, respected teachers. So wait. Sir, sir,
You have to just go to share screen.
Share the slides and we remain cool.
yes, sir.
Share, you have a button down, no? Share screen, green color. Share the
Ma'am,
screen.
I'm-
Put your PPT and put it on slideshow mode, then you can hit the share screen button.
yes.
You just have to go to the PPT, open it, and then put the share screen and then share that PPT. That's it.
Yes.
Hello.
Hello. Yes, ma'am.
Sir, are you able to share your screen?
It's not able to share, ma'am.
I'll drop
can
my
s-
email.
Did you email these slides to Dr. Smita?
Yes,
Okay, Dr. Smita,
I'll
please go
drop my
ahead.
email ID in chat box. Then
Okay.
just quickly share this.
Okay.
Yes. Yes, yes. I think I got this.
Sir, I drop a mail on chat box.
Yes.
In the meanwhile, I think there are no further questions. Otherwise, we could discuss one question. Somebody had put, Asmita, we are not seeing the poll option. Was it there or not there?
Yes, ma'am, the poll is on.
No, because and just now I saw the chat box. It was written, we are not seeing, because I also didn't get it. Normally, I get it on my screen also. I didn't get it today. So I was also not sure. I thought maybe for panelists, it's not showing up, but are you sure? No, it was there because
56 participants had already submitted the answer.
then it is fine. Then it is fine. But some people didn't see because it didn't come on my screen also. So maybe there was some technical snag. Have you got the slides, Asmita?
No, ma'am, not yet. Meanwhile, can we discuss the quiz answers?
Yeah, I think we can do that. But normally we announce the winners in the end. So
Yeah,
we don't
Announce the winner at the end, but can we discuss the
Okay,
options?
fine. We'll do that. I think if it's taking time to, but Dr. Siddharth
Ma'am, yes.
has. Are you able to send the slides to Dr.
yes,
to
ma'am.
Asmita?
Yes, ma'am. I'm just saying.
Okay, so then what we'll do is we'll discuss the quiz answers, but we'll not announce the winners.
Better.
So, Dr. Lisa, if you're fine, can we have the discussion of the quiz answers in the next 10 minutes? And in the meanwhile, I think Siddharth will be able to get the slides on.
Sure. I'm fine with it. No problem at all. But I'm concerned that some people could not submit it. But I hope they have the answers.
She has got 56 things. So I think everybody got it. One person maybe didn't get it.
Right, right. So, yeah. So moving on to the answers of the quiz. So true about McCune-Albright syndrome. So the answer here is nodular goiter. This is because McCune-Albright is a gain of function of the genus mutation, post-zygotic mutation. But so this is a gain of function of the TSH. As one would expect that a diffuse toxic goiter is more commonly seen, but nodular goiter is also reported in nearly 35 to 50% of patients. Thyroid cancer is actually exquisitely rare in McCune-Albright, and it's totally anecdotal, hardly a couple of cases reported, so it's definitely not common. And regarding the treatment of choice, though there is no clear consensus, but antithyroid drugs have a definite limitation in the sense that once you withdraw the drug, the hyperthyroid state is going to recur because the TSH gain of function is constitutive, and hence radioactive iodine is the treatment of choice. And as per se, because of the genus activation, it is a T3 over-circulating syndrome. So it is a T3 toxicosis, just like any other hyperthyroidism. So the answer here is B, or the second option, nodular goiter. So this is the question number 2 regarding hypothyroidism after subacute thyroiditis in a very elegant study done from India. Which of the following is false? The answer is actually option 1, because the severity of subacute thyroiditis was in fact found to determine the development of hypothyroidism at follow-up, in the sense that people who had more severe SAD or lower TSH at baseline, they had a higher propensity to develop permanent hypothyroidism. And permanent hypothyroidism was seen in actually just short of 20% cases at 1 year of follow-up. And with longer duration of follow-up, as seen in other studies, greater prevalence is certainly there. And this is interesting because if an episode of SAD is there, nothing prevents that person from having another episode. But it is uncommon. It is reported in up to 2% of cases. So question number 3. So tyrosine kinase inhibitors. So we have quite a couple of them in clinical use with us, starting from sorafenib to vandatinib to lenvatinib. So the following is not an adverse effect. Hand-foot syndrome, all of us are very well aware. This is in fact one of the commonest side effects. And but fortunately, it is mild and rarely severe. Bowel perforation has been reported in these patients. And this bowel perforation is a side effect of the drug per se. It is not due to a metastatic deposit of the MTC. Then glomerulonephritis, especially the MPGN or the membranoproliferative glomerulonephritis is also reported. Hyperthyroidism is certainly not an adverse effect, but rather hypothyroidism may be seen. Regarding thyroid eye disease, so option 1 and 4 quite clear that they are wrong, because we know that unilateral tau is all of us must have seen one or more cases, and up to 10% of cases may have hypothyroidism or maybe euthyroid. Graves is not always an accompaniment. Superior rectus is certainly not the most common extraocular muscle involved. It is the inferior or the medial rectus. And in fact, if it is isolated superior rectus involvement, we should think of other pathology like we had in this patient, because she had a non-axial or an eccentric proptosis, isolated superior rectus muscle involvement. And here, as in the MRI, we can appreciate a mass apart from the inferior and medial rectus being involved. So she had a thyroid eye disease, but she also had a mass there, and biopsy was done, and she had an orbital lymphoma. So it can coexist with ocular pathology. Then about IGSF1 deficiency, immunoglobulin like superfamily 1 deficiency. So it's a relatively new disease described only a decade back, but it is of date the most common cause of congenital central hypothyroidism right at present. And actually the syndrome as such involves central hypothyroidism and macroorchidism. So macroorchidism is a telltale sign, and it is an X-linked recessive type of disease. And here, because the concomitant deficiencies that can be seen are actually deficiency of growth hormone and prolactin. So hypoprolactinemia is seen, not hyper. So answer here is option 1, the most common cause of congenital central hypothyroidism. So teprotumumab, which of the following is applicable? This is the landmark trial in NEJM with small number of patients with very significant results. So which is applicable? Here the answer is it is prescribed in a weekly dosing by the intravenous route, Actually, it is, I mean, the initial dosing is 10 milligram per kg and subsequent doses are up to 20 milligram per kg. Okay, I'm slightly, this is not exactly weekly dosing. It is given every 3 weekly, but it is not orally administered. It is not used for myxedema coma for sure. It has been used in a couple of cases of pre-tibial myxedema. And it is not FDA approved only for active thyroid eye disease. It is across the spectrum, so irrespective of activity or severity. So here the answer is option number 4. Then regarding thyroid dysfunction and proteinuria, so not very commonly discussed aspect, but due to multiple alterations in the protein handling machinery of the kidney as well as the renal blood flow, so proteinuria is reported. Reversible eGFR decline is reported because of the reduced renal blood flow. And also in prospective studies, it has been shown that on replacement, both the proteinuria, I'm sorry, even severe proteinuria can be reduced and the eGFR improves. But here the catch is that the minimum duration in which this improvement is seen is as early as 3 months, and the improvement persists. And here, hence the wrong answer is 18 months because the improvement is seen as early as 3 months. So next question about TSH-oma or TSH secreting pituitary adenoma. It is an uncommon tumor, but nevertheless, it is very commonly misdiagnosed if we get only a TSH done, and the patient is usually given levothyroxine suppressive therapy and the TSH does not suppress, and then then usually there's an MRI in the course of the disease. So this is regarding TSH-oma. So here the correct answer is surgery followed by somatostatin analogs or radiotherapy can be used for treatment. Hyperprolactinemia is never a feature. Now, interestingly, these patients can have either hypo or hyperprolactinemia. Hyperprolactinemia can be there because these masses are usually macroadenomas, so due to the stalk effect. But hypo can also be seen because it's an autonomous TSH secretion, so that in a feedback fashion, it inhibits the TRH, and so the prolactin can be low. And contrary to other thyroid disorders, there is no gender predilection for TSH-oma. So males and females are almost equally affected. And the cases are actually most commonly, whatever cases are reported, they're most commonly diagnosed in the 5th to 6th decade, not so early in life. So regarding myxedema coma, which the following is applicable, it is more common in elderly females actually, not males. And it is not only reported in drug defaulters. They form a majority of the patients who present with myxedema coma, but also around 20 to 50% of patients can have newly diagnosed hypothyroidism presenting as myxedema coma. So that is there. So this statement is false. Mortality in this condition, unfortunately, even in contemporary cohorts, the mortality is quite high. But what is true here is that the Apache 2, the SOFA, and the myxedema scores all have been used for prognosis in these patients. Myxedema score is again a clinical score which has been devised using multiple parameters. And here a score of more than 60 is actually suggestive of myxedema coma. So it is used not only for diagnosis, but also for prognosis in these patients. So alemtuzumab induced thyroid dysfunction. Alemtuzumab, if some of us are familiar with the neurological use, actually, it is a drug of choice for multiple sclerosis. And the most common adverse effect is actually thyroid dysfunction of this drug. So which of the following is false? So both hypo and hyperthyroidism can be associated. That is a true statement. TRAb levels are in fact highly positive. Alemtuzumab induced Graves' disease as compared to conventional or common garden Graves' disease, it requires a longer time for normalization, possibly because of high TRAb levels. All these three statements are correct. What is wrong, or what is the answer to this question is actually thyroid eye disease has a better prognosis than Graves' disease. That is false, because thyroid eye disease is uncommon and it fares worse as compared to Graves' disease. So the last question regarding the perioperative management of non-thyroidal surgery in a patient with known thyroid disease, which is most appropriate. So ketamine is the induction agent of choice for hypothyroidism. That is correct, because ketamine actually it has got its sympathetic activity. It's an inotropic agent as such. And that is the correct answer. For hyperthyroidism, the agent of choice is actually sodium thiopental because it has some antithyroid activity. And if postoperatively in a patient, parenteral T4 is required in a hypothyroid patient, so the dose requirement is actually 70 to 80% of the oral dose requirement. And prior to cardiac revascularization, this is probably the only scenario where LT replacement is not mandatory, because as you would expect, there can be increased myocardial oxygen demand, and hence the cardiac outcomes may worsen. So the revascularization is done first. So the answer here is option number 2.
So thanks, Dr. Lisa. Just stay with us because after the case discussion, you announce the winners.
Okay.
So Asmita, did you get the slides? Can you share now?
Yes, ma'am.
Okay, go ahead. Thank you, Pramila, for managing. But I think that's good. We tried to save some time.
Yeah,
there.
Dr. Siddharth, you can start now, please. Yeah.
Siddharth had some problems here, managing. So sorry for it, please.
Sorry.
No worries, no worries.
It's okay. It's okay. No
They're
problem.
all,
Don't worry
they're
about
all learning, so that's fine.
it. It's all a part of learning. No props.
Good evening, respected teachers and all of who have joined here. I am Dr. Siddharth. I am today presenting a case today of a 38-year lady, homemaker and resident of Pitampur, Indore. She was referred from obs-gynae to endocrinology for evaluation of possible thyroid disorder. Next slide. She presented with chief complaints of excessive weight gain for 2 years, excessive hair fall for 2 years, and irregular menses for last 2 years. History of presenting illness: the patient was apparently all right 2 years back when she started experiencing weight gain despite poor appetite, excessive hair fall, irregular menses. Her normal cycles were of 28 to 30 days, but she started having increased bleeding and cycles were reduced to 15 to 20 days for past 1 year. And from last 6 months, she had decreased volume of blood and cycle duration increased to 45 to 50 days. She also had fatigue, slowness of movement, sleepiness, change in voice was noted by attendants, constipation, difficulty in getting up from sitting position, and swelling around the eyes and lower limbs. She also complained of headache on and off, which was of holocranial type, mild to moderate intensity, not associated with nausea or vomiting. There was no history of joint pain, sweaty hands, acne, or change in size of slippers. No history of abnormal skin pigmentation, postural hypotension, dizziness, or any hypoglycemic episodes. Past history: no history of thyroid disorder, diabetes, hypertension, tuberculosis, no history of any cardiac or neurological illness in the past, no history of any trauma or surgery in the past. Family and personal history: diet was mixed type, appetite was reduced from 2 to 3 chapatis a meal to 1 to 2 chapatis a meal 3 times a day. Sleep was excessive, 10 hours in the night, and daytime sleepiness was also present. Previously, it was only 5 to 7 hours. Patient was having constipation. There were no addictions. Menstrual history was menorrhagia, was followed by oligomenorrhea. Here is are the pictures of the patient, and here is a video which can we can see the we can hear the hoarseness of the voice of the patient. If we can play the video, ma'am.
मेरा नाम सत्यानाम है, रहने वाला काका।
Here we can hear the voice present in the patient. Ma'am, next slide. Cold intolerance was also present. Next slide. On general physical examination, height was 158 centimeter, weight was 53 kgs, BMI was 21.2 kg per meter square, pulse rate 60 minute, regular, normovolumic. Blood pressure was 100 by 70 mmHg in left arm supine position. There was no postural drop. JVP was normal. Severe pallor was present. No icterus, cyanosis, clubbing, or any lymphadenopathy was present. On general physical examination, hair was thin, brittle, generalized loss of body hair was present. Loss of hair was seen more in the occipital region. Face, she had puffy eyes, broadened nose, thick lips, and thick nasal folds. In oral cavity, no abnormal pigmentation was found. Tongue was enlarged and no glossitis was present. Skin was dry and rough, cold dry hands with yellowish tinge. Thyroid, no palpable goiter. Bilateral galactorrhea was present, which was expressed. Pretibial non-pitting edema was present. Bilateral diffusely enlarged calf muscles were present. This is the, you can see the loss of air in the occipital region, which was present in the patient. Ma'am, next slide. Systemic examination, cardiovascular and respiratory system examination were normal. In per abdomen examination, abdomen was soft, non-tender, no organomegaly, no ascites, bowel sounds were sluggish. CNS examination, higher mental functions were normal, cranial nerves normal. Speech was slow, hypophonic, difficulty in pronouncing full words. There was no delusion and hallucinations. Now coming on to the motor system examination, in both the right and left side, the bulk was increased in bilateral calf muscle, tone was normal, and both the muscles of upper and lower limb, proximal muscle, had weak power of 4/5. And you can see the deep tendon, delayed deep tendon reflex in this small video. Ma'am, please, you can play the video. We can see the delayed hung up reflex of the patient. Sensory system findings, there were no sensory deficits and no cerebral signs were present. Ma'am, next slide.
Dr. Siddharth, why do you think that that has happened, that delayed relaxation in this case?
Sir, delayed relaxation is that there is increase in the relaxation time, sir. That's why, sir, it is.
You think it is effect on the nerve or effect on the muscle or a combination? In this case.
Yes, sir. Sir, due to the effect of muscle, sir, there is sir, increased type 1 fiber. Yes, sir,
Okay. Okay. We'll go ahead. We'll go ahead. Okay, right. We'll go ahead. Okay.
The summary of the case: 38-year-old lady presented with weight gain despite poor appetite, irregular menses, excessive hair loss with coarse facial features, dry, rough skin, bradycardia, pallar, bilateral calf muscle hypertrophy, and delayed deep tendon reflexes with no acromegaloid features and no features of autoimmunity. A provisional diagnosis of hypothyroidism with
Do you have any thyroid swelling or anything you're not emphasized? Do you want to emphasize here about the thyroid swelling presence or absence?
So there was no thyroid swelling.
So there's no thyroid swelling. That you need to emphasize here because it's a typical case. So that has a bearing. Whether it's non-goitrous or goitrous, from the beginning itself, we'll have some understanding, right? Regarding the etiology, right?
Yes.
So there's no goiter. No clinical autoimmune features. No features of autoimmunity. You're saying that means you're suggesting us no clinical autoimmune markers, right? That's what you want to say?
Yes, sir. On the basis of this, the provisional diagnosis was made of hypothyroidism, hypothyroid myopathy, Hoffman syndrome with severe anemia. Investigations were done. HB was 6.4, MCV was 105.8, rest TLC platelets were normal, AST was mildly raised, creatinine was also normal.
Why it is called Hoffman syndrome? You said it's a typical hypothyroid, no? Why should we think about Hoffman syndrome here? What is Hoffman syndrome?
There is swelling of there was swelling of calf muscles, bilateral calf muscle. There was hypertrophy of bilateral calf muscles, and there was associated with proximal muscle weakness.
Proximal muscle weakness is there, as well as the swelling. So do you think that some pathology is there inside the muscle because of long-standing hypothyroidism? That's what it is there, is it not?
Yes, sir.
So that's the reason it has a typical clinical entity name is given. Okay, that is what you're going to tell us. The neuromuscular manifestation of hypothyroidism you're going to present. That's what you're saying, is it not? Hoffman syndrome. That's what you want to indicate, that there is severe neuromuscular presentation here of hypothyroidism. That's what you want to say? Okay, yes, that's good. Carry on. Okay, let us see the corroborative evidence from the investigation. Yes. Right.
Next slide. Hormonal investigations. TSH was found to be raised more than 100. T4 and T3 were below normal range. Anti-TPO was positive, more than 1300. Serum prolactin was 42 nanogram per ml. serum cortisol fasting ATM was 9.8 milligram per DL, and CPK was found to be raised, which was 2,263 units per liter. Radiological investigations, chest X-ray was normal because she had a complaint of headache. X-ray lateral view of skull was also done, which showed widening of the pituitary fossa. USG whole abdomen showed normal study. 2D echo showed grade 1 LV diastolic function, dysfunction, trivial MR, ARTR, normal LV systolic function, and no pericardial effusion. So this is the X-ray skull of the patient. We can see the arrow pointing towards the widening of the pituitary fossa, which could be due to the pituitary hyperplasia, which presents in the patient with long-standing untreated hypothyroidism. And
More than this, what do you want? Okay. That's,
Yes,
I think a bit more emphasis is being given on this. I mean, that's not needed. Okay.
Yes.
But then something else in the hormones, you didn't say something else. Because in the presentation, you said about the reproductive endocrinology features. No, some organic features, you said menstrual disturbances she had. Galactorioles, you said that bilateral expressive galactoria was seen. You're projected in the examination. So relating
Yes.
to that, what hormone you have done?
So lectin was done, sir. 40, it was raised, found to be raised.
How much was it?
42, sir, mildly.
42. So you consider it as hyperprolactinemia or mild hyperprolactinemia was there? Was there? Sure.
Yes,
Okay, you're sure, no? Okay,
yes,
fine. Okay, then what else related you will see in this investigation? Yes, you can, if you have done an abdomen ultrasound, pelvis ultrasound, if you want to project, you can project.
yes.
No, you've not done? Do you think it is relevant in this case? Abdominal ultrasound, pelvis?
Yes, sir, yes.
What is the relevance? Quick, because
So
this time.
we can see sir, found enlarged multicystic ovaries in this patient.
Okay,
It can
okay,
present with abdominal mass. We can
okay,
find palpable mass also.
okay. Right. So that means you have projected in the history that initially she had regular cycle with excessive flow, that is menorrhagia, and gradually she ended into oligoamenorrhea. That's what you said. So that means in ovary, though you don't have a typical, whatever you said, the doctor, the other presenter said about cystic appearance in the ovaries, multicyst and all. She may be having, may not have also, but you can have the so-called polycystic pattern of presentation also. That's the reason you need to rule out secondary PCOS in the evaluation of in diagnosis of primary PCOS. Right? TSH is part of the evaluation in PCOS later. Right? That's the reason here you have to oligoamenorrhea, hypothyroidism also can present with PCOS like picture. That's the reason ultrasound may karna. Besides that, of course, you'll have cystic appearance of the ovaries and all that typical problems with that. Yes, carry on. Yes.
Ma'am, next slide. MRI was also suggestive of pituitary hyperplasia. Ma'am, next
Any vision
slide.
disturbances were there? No.
So
Okay.
there was a history of headaches only.
Okay, fine.
So this
Check.
picture shows the hypertrophy in bilateral calf muscles.
Okay.
Final diagnosis was made of long-standing untreated primary hypothyroidism of autoimmune etiology with hypothyroid myopathy, Hoffman syndrome, with pituitary hyperplasia with severe anemia.
मायापति कैसे भाई ENMG या NCV कुछ निकाले करे नहीं only something you have done, anything you want to project? No.
So EMG sir, was not done. Sir.
ENMG was not done. Okay. Do you expect some differences in ENMG?
Yes, sir. We can find the myopathic jittery pattern is seen, sir, in EMG.
Okay. Okay. Right. So right.
The management, a patient was started on 25 microgram levothyroxine, which was gradually uptitrated to full dose. Blood transfusion, iron, folic acid, B12 supplements, and supportive treatment was given. Now, the discussion about the hypothyroid myopathy. Hypothyroid myopathy is the presence of generalized myalgia and muscle weakness with proximal myopathy. It is present more in women than men. It is found in uncontrolled hypothyroidism. It is seen in both congenital and adult forms of hypothyroidism. Now, the Hoffman syndrome. It was first described by Hoffman in 1897. It depends on the severity and duration of hypothyroidism. It is seen in adults, mainly characterized by pseudo hypertrophy, painful spasm, proximal muscle weakness, and stiffness. The muscles commonly involved are the leg muscles. However, thigh, forearm, and arm muscles may also be involved sometimes. In childhood, it is known as the Cocker-Debré-Simlange syndrome, which is associated with generalized lower extremity muscular hypertrophy, mixed edema, short stature, and cretinism. Pathophysiology is the thyroxine deficiency leads to reduced mitochondrial oxidative capacity, abnormal glycogenolysis. This leads to selective atrophy of type 2 muscle fiber, which are the fast twitching type, as they are dependent on glycolysis for energy, causing the slowing of muscle contraction, seen clinically in patients with hypothyroidism. The muscle involvement in hypothyroidism is caused by alteration in muscle fibers from fast twitching type 2 to slow twitching type 1 fibers, deposition of glycosaminoglycans, poor contractility of actin myosin units, low myosin ATPase activity, low ATP turnover in skeletal muscles. There is also a decrease in muscle carnitine in patients with thyroid dysfunction causing myopathic symptoms.
But
Now
you think
that
vitamin D have you done here? Vitamin D haven't done? Should have
no,
done, no? Because anything which directly, indirectly affects, is it not? You should have done it, right? Okay, right.
Now the learning points from this case, Hoffman syndrome carries favorable prognosis once hormone replacement is started and most of the symptoms regress with time. Hypertrophic calves typically return to normal after approximately 3 months of the treatment. Hoffman syndrome represents those few forms of myopathy that completely reverses on prompt therapy. Pituitary hyperplasia occurs due to lack of negative feedback on the hypothalamus, resulting in elevated TRH. The elevated TRH results in thyrotroph hyperplasia in the pituitary. The thyrotroph hyperplasia may also be accompanied by lactotroph hyperplasia induced by the TRH, which explain the hyperprolactinemia and galacturia in this patient.
Okay.
Patient can also present with features of hypothyroidism, hyperprolactinemia. Visual field defects can also present if the hyperplastic pituitary gland compress the optic chiasm. Pituitary hyperplasia is an under-recognized manifestation and can mimic a pituitary mass. Regression of thyrolactotroph hyperplasia usually occurs within 2 to 12 months of starting thyroxine therapy. Failure to regress after optimal therapy with normalization of TSH suggests either a long-standing thyrotroph hyperplasia or concomitant presence of pituitary adenoma. Now the take-home message from this case are long-standing uncontrolled hypothyroidism can present as a various symptom complex. Thyroid myopathy is a very classical and reversible complication of long-standing untreated hypothyroidism. When treated promptly, it can be a life-altering for the patient. And thyrolactotroph hyperplasia should be differentiated from pituitary adenoma as it can lead to unnecessary surgical interventions. Thank you, sir.
So what is that in management? What is that you'll take care? Because you said there's a hyperplasia, same, whatever we discussed in last case also has some bearing in this. So you also have to be gradual, systematic, also ruling out the cortisol aspects because pituitary hyperplasia is there. So that's the reason that otherwise, but some of them are not totally reversible, calf hypertrophy, because of glycosaminoglycan deposition and structural alterations also to some extent can be there. Reasonably, they can be reversed, but not, I mean, maybe 20-30% of patients may not totally, myopathy may not totally be gone. Okay, and neuropathy may be associated slightly. Most of them is sensory neuropathy, which is reversible, but some of them can have associated because these people can also have B12 associated B12 deficiencies because pernicious anemia and maybe some mineral deficiency. All this may be. So that's the reason you have to think of.
Yes.
Any questions there or?
Yeah,
I think
Yeah,
time is,
one
yeah.
question is CPK is it raised?
no, but it is already then the next.
Yeah, that is
question,
what those are the two questions. So we
Yes.
have done it already. Yeah.
No, in adults, gradual increase in thyroxine dose. Does it have any advantage over starting full dose? I think Jayanti just answered that, but could you do it
Yeah.
again? Isha is asking. Siddharth?
Yes, ma'am. We should start the dose titration gradually, as these patients are also predisposed to adrenal insufficiency. So we have to take this step-up approach. Hydrocortisone should be also precede before the starting of thyroxine if there is cortisol deficiency in the patient. Because if we start the full dose, it can lead to the increased metabolism of the cortisol, and which can patient can precipitate in adrenal insufficiency.
And Amod is asking about muscle biopsy histopathology. I'm sure that is not warranted, but I'm sure it wasn't done either.
Yes.
I mean, we would assume that it's all hypothyroidism, and if by remote chance it doesn't get corrected, then within the stipulated time, then we might give that a thought. But otherwise, it is not usually warranted.
Yes.
I mean, I don't think you can even publish this as a case report. So I think Pramila might be happy to have both of them anyway.
I think
And
follow-up
one
and documentation. I mean, if you have not started, I think you should have a ENMG, and I think follow it up nicely. And Dr. Pramila will surely take up maybe after 1 year follow-up is important, where you can regress this thyroid hyperplasia, can document and other things.
Almost
Surely,
2
it's a good
months
thing.
have passed since that we started treatment. We can always call her and do it. Almost 2 months have passed.
Then
Yeah, 6 months to 1 year follow-up. If we have, then we can definitely have the data.
And some myoglobin electrophoresis done. Amoda is asking. I don't think so. I'm not.
Not
Well,
really.
Siddharth?
Not
I think
we have answered the
endocrinology should
question.
play primary sufficient role here. Normalize the thyroid status and the general status. Follow up, not much of difference. Then we may think call in rope in other specialists, neurologists. But I think we should stick on to simple and basic treatment and follow up here. That'll give rewarding results here.
It's quite rewarding. Many things they revert back. Even the muscle bulk may go down, may take years, as rightly said. Yes.
Yeah.
So I think
yes. So should I hand over to Dr. Sarita Bajaj and Dr. Pramila, thanking both the speakers and my dear friend Dr. Jayanti Raman. Thank you very much.
Thank you, madam. Thank you, sir.
Indian Thyroid Association, all of you, Dr. Sarita, Dr. Pramila, thank you. Nice of you. Thank you very much. Over to you, please.
Yeah. So we'll just have the quiz winners. So Dr. Lisa,
you say, thanks Siddharth and Soumit, you presented well. From Dr. Jayanti and Dr. Sarita also, I am thanking you. Bye. Thank you. Over to you, Pramila, please.
Yeah, Dr. Lisa will tell the quiz winner's name. So Asmita, can you put Dr. Lisa, can you announce? Yeah.
Yes, thank you, ma'am. And I hope it was a mixed bag, and I hope you got something to learn, just like I did. So congratulations to the winners for today's quiz. So the first position is backed by Dr. Lal.
This is for 10th October, the 10th, the one which we had put online. That
is the I think that is the teaser.
Yeah.
The teaser questions.
Yes.
Those ones.
Great.
Yeah.
So nevertheless, congratulations to Dr. Lal Chand, Dr. Amardeep Singh Dugal, 2nd spot, and Dr. Nikhil Bes, 3rd spot. So congratulations to all 3 winners. Okay, here we have the winners for today's quiz. So in 1st spot is Dr. Vibhu Ranjan Khare. Congratulations. 2nd position, Dr. Rachna Kishore. And 3rd position, Dr. Abhijit Javanjar. I apologies, if I am pronouncing it wrong. But congratulations to all the participants and to the winners for sure.
So thanks, Dr. Lisa. Thanks for announcing the winners and the excellent quiz as well. And obviously the cases were very nice because we tend to discuss all the complicated cases, but the things which are actually missed are the basic cases. So we need to definitely give this message that the basic cases of hypothyroidism, especially even congenital hypothyroidism, we also see so many undiagnosed congenital hypothyroidism coming later. Even now we see that in our country, so which is quite unfortunate, but we do see, and juvenile hypothyroidism as well, like this patient, and adult hypothyroidism, myxedema coma also we see so many still, in spite of so much of awareness. So this is very, very important to diagnose them on time, because they may go to many different departments and they may not be picked up, and a simple test of TSH and T4 is not done. So that is the basic message which was communicated through the two case presentations by Dr. Somin and Dr. Siddharth. And Dr. Jayanti, you excellently moderated the two cases as well, and Dr. Subodh, your chairing was very nice.
Thank you.
And Dr. Sarita Bajaj ma'am, she's always there with us and guiding us through with all these thyroid clinics. So I thank our technical team as well, because they are always there to support us in time of need whenever there's a crisis which happens like this. So I hand it to ma'am also to say the final words, and then we'll tell the dates for the next two sessions, that is in November and December.
Oh, thank you. Thank you, Pramila. Hypothyroidism just never ceases to amaze me. The spectrum, right? See, even from the simplest of cases to the ones that were presented today. They were referred, I'm not sure whether the first one was referred from pediatrics or from OBGYN, but the second was referred from OBGYN. So like Pramila rightly said, they can present in any department. And even considering that left, right, and center thyroid functions are being ordered, to actually believe that in this day and age, you can have a child of 6 years with a bone age of about 2 to 3 years. I mean, keep your fingers crossed and toes crossed. And yeah, this child should be able to have a decent catch-up growth. But if it was even congenital, sometimes we see them at the age of 4 years, 5 years, 6 years, when as far as mental retardation, there's so much deficit. And of course, the catch-up growth is not there. Now, this woman, just look at her. I mean, all classical signs, textbook picture, which you would have, I mean, like it was so much fun to see all that. In our time, if you remember, Dr. Banjal and Jayanti, we used to do photomotograph. I mean, to see the delayed ankle reflexes, and that was one of the ways of diagnosing. Of course, we don't do that any longer, but it's unbelievable. It's unbelievable. And you feel so disappointed that you're trying your best to get thyroid tests performed, at least where they are relevant and not where they are not required when the master health checkup going on, isn't it? So excellent. Both Somin and Siddharth, thank you very much. And of course, Subodh, thank you, because I think you are the ones who helped in the selection. Considering they've just joined, I believe, they're your very, very first year residents in your DM program right now. Anyway, so congratulations for having started the program. And Jayanti also took, I think, us back to our student days.
Yes.
Because he was, really grilling them thoroughly, which is, thank you so much. It's lovely.
I want them to stand tall and become the best.
Yeah, since we interacted during the ICUE.
Yeah.
Remember that? I think that was 2014.
Yes, ma'am.
Yeah. So anyway, wonderful seeing you, and thank you.
Thank you very much, ma'am.
Thank you. For chairing, Jayanti, for the moderation.
Thank you, Dr. Sarita,
excellent.
Dr. Pramila, and everybody. Thank you, Dr. Jayanti. Very nicely done. Thanks for that.
Lisa, the quiz was wonderful. Thank you so much.
Thank you.
And Pramila,
it was
we
really
need to go on pursuing them to send the cases.
So we have to learn more. Thank you.
Yeah.
Thank you very much. Thank you. And thank you, of course, to Smita and Vidhi, who are with us for every program.
And Dr. Lisa, who was like nicely organized.
Again, congratulations to the quiz winners.
Yeah. The quiz master and the quiz winner both.
Makes it very, very
interesting.
And more participants as well. Thank you, Lisa. Very well done.
Thank you.
Thank you very much.
Thanks everyone.
For the next 2 sessions.
Yes, so this is for the next thyroid clinic, that is on 8th of November. So please join us on 8th of November, and we again have very interesting articles to be discussed, and the next one is on 20th of December 2023.
That will be the last one for this year.
That will be the last, for the year. So good night, everyone, and thanks for joining today. And I think we all learned today many new things, and we have become more wiser.
Thank
you.
Good
night.
Good night. Thank you. Thank you so much.
Good night, everyone.